1, 2. Right, 1 minute, everybody. Last drinks and coffees and whatever. I'll just let this cabling. I'll give you a wave when the cabling's done. Okay, are we ready, team? Should we press go? Yep. Right. Good morning, everybody, and welcome to the Suffolk and North East Essex Integrated Care Board meeting for November. Lovely to see you all here in this wonderful room and location. And a number of people have said to me how Christmassy it's looking, but it also is a fantastic room and resource, isn't it? So lovely to be here. Don't forget, everybody, that we are live streaming. And then a couple of housekeeping points. Toilets are in the lobby, off the lobby to my right at the bottom of the room, and no fire alarm planned. So if one goes off, we assume it's the real thing. And fire exits, again, the way you came in through the lobby, and one over on my left here, if needed. So first of all, apologies. So first one is from Moira McGrath, who's been deputised by Pete Devlin, but we don't have Pete with us yet, so I hear he's on the way. Richard, apologies from Richard Watson, but Narinder, thank you for deputising. From Caroline Donovan, Kath, thank you. Apologies from Lisa Nobes, but Sarah, you're deputising, thank you. Also apologies from Kirsten Alderson, Sam Glover and Andy Yakub. Have I missed any, Tom?
Just the welcome, Clement.
Yes, I've got welcomes to do, but no more apologies. Lovely. So thank you for that. So welcome actually to Tina and Lisa, who are going to speak on one particular item, but also Clement for Suffolk County Council, your first in-person meeting, I believe. Would you like to say hello, Clement?
Hello, good morning, everyone. My name is Clement Mawoyo, representing Suffolk County Council. Really good to be here.
Lovely. Thank you, Clement. So questions from the public. We've had 4 questions raised prior to the meeting, which we'll take in the public session at the end in the normal way. Simon, have we had any more that you're aware of? Tom? No? Okay, thank you. Declarations of interest. Are there any declarations of interest or potential conflict of interest with any agenda item? Nick?
Yes,
Thank you, Nick, which is item 9. So thank you for that. Any others? No. Minutes of the last meeting, 24th of September. And as you'll remember, that was a very complex meeting, actually a very emotionally charged meeting as well, wasn't it? The minutes, the initial minutes that went out did contain a typo ascribing parts of the public session to the wrong questioner, which Tom immediately corrected, I think within 10 minutes of it being on the website. So did you want to add anything to that, Tom? Is that complete? So with that correction, does anybody have any issues around truth and accuracy with the minutes as on the website? Andrew?
Just over the irritating typo, sorry, Will. 4.2 Darren, D-A-R-R-E-N.
Ah, right.
Thanks.
Good spot. Good spot.
And I think it might be an E in the end of Thorn as well, so worth checking.
Thank you.
Okay, we'll leave that to you to check. So any other points? So subject to typo corrections, is everybody happy to approve as a true and accurate record? All done, approved. Thank you very much. Thank you, Tom. Complex minutes indeed. Matters arising, it's our task today to review and endorse, but I think there is only one item in the papers that you have before you, which is relevant, and that's the ME and the CFS long COVID that we've already referred to as an action, but is on the agenda for today. So I think done. The others, according to my checking anyway, were not due until January, March and May 2025. Is everybody happy with the matters arising, the action log, therefore, as presented? And are there any other matters arising or actions that you feel should have been captured from the last meeting which haven't been? Andrew?
So just an update. We spoke about an assurance exercise for the safety of physicians associates. That's underway, and we're planning that should go through the relevant committees to be ready for board in March, if you want to hear an update then. So just set a timescale for that.
Yeah, that would be useful. Should we make a note of that, Tom, and add that in? Update in March, Andrew? Lovely. Thank you very much. Anything else? So with that addition, again, is everybody content to accept the matters arising and action log as true and accurate? All done. Lovely. In which case, item 6, the CEO's update, and over to you, Ed.
Thank you, Chair. Got a long list of things to update on as normal. First, I just wanted to congratulate Nick Hume and the team at ESNEFT for the delivery of the Elective Orthopaedic Centre in Colchester, which is absolutely world-class facility, 72 beds, 8 theatres and 300 jobs created. I think it's a 60 million plus investment for our community. It's worth reminding ourselves that it's named after Dame Claire Marks, who's unquestionably our finest leader that we've had in SNE, and she was the first female president of the Royal College of Surgeons and the first female president of the GMC, alongside all of the work she did clinically here in SNE. So very appropriate that her legacy is recognised in this way. And thank you, Nick, for all of your personal leadership in delivering this over a 7-year period. So it's a really, really proud moment, I think, for all of us, and fantastic for our patients. Building on the theme of estates, so by the time we next meet, the Newmarket Community Diagnostic Centre will be open, and we've seen footage of the new centre. It's pretty much there. It looks absolutely brilliant. And equally, we understand that the business case for an equivalent facility in Ipswich is now moving forward too. So we'll have one in Clacton, one in Newmarket and one in Ipswich in the near future. So really, really exciting, and will help support the elective recovery significantly. Equally, we now have the new hub at the ambulance service that's opened in Bury St Edmunds. It's the largest of its type in the UK. It houses 33 ambulances, has a make-ready facility and fantastic facilities for the staff in terms of their well-being. So perhaps, Chair, I know there's a large meeting room there. We might meet as a board there so we can have a bit of a tour of it. It's really genuinely impressive. However, on estates, I just wanted to record a public apology to the people of Ipswich. We were unable to deliver the new GP surgery that was planned on the Tooks Bakery site due to the rising inflation of that development. Maddie and I are, however, working on a plan B, and we hope to report a way forward very soon. So we are determined to deliver new facilities for the people of North West Ipswich. Turning to productivity, I'm very pleased to share with the board that our system has the highest or best performance in terms of productivity in the NHS at month 5. So we've seen an 11% implied workforce productivity growth at month 5 compared to 2023-24. It's mainly been driven at ESNEFT, where I think they're delivering a 13% increase, and also an increase to a smaller scale at West Suffolk, but overall a fantastic position to be in, and reflects all of the hard work in the system and exactly where the government want to see the NHS be. So that's really encouraging. In terms of SEND in Suffolk, which has been a challenging area, as we know, it's been reported to the board, we've received a letter from the Department of Education recognising improvements. So we want to see those improvements sustained, and perhaps Lisa Nobes might want to update when she's next at the board on the work being done. And equally, in terms of difficult challenges, I just wanted to recognise the excellent progress being made at the Norfolk and Suffolk Foundation Trust under Caroline Donovan's leadership. So the Friends and Family test score has improved by 20% in the last year. And that was noted at the quality committees, and there are other important indicators of progress. So we're really pleased to see the data moving forward at NSFT under Caroline's leadership. Finally, before I come to more national concerns, just wanted to recognise that we've appointed a new allied health professional officer for the system, Penny Casson, who's well known to us, has been working at ESNEF for some time. She's putting a huge amount of energy and leadership into this agenda, and it would be good to invite her along again to the board to talk about the work she's doing for supporting AHPs in SNE. Finally, in terms of national concerns, obviously we're very grateful to the government for the budget, to see the increase in resource for the health service. I think without it, it would be an extremely challenging situation. However, we're very interested in the national insurance contribution concern for both primary care, social care and the voluntary sector, and are awaiting more guidance on that issue. I think that's a very, very big issue across the country and equally in SNE. There has been a lot of press coverage recently around national accountability and oversight arrangements for the NHS, which will be brought forward in the coming weeks. But I think the general shape of it is that systems that are delivering reasonably will be given more autonomy, and those that are delivering less so will be given more support. And then finally, very significantly for us, I think, the devolution white paper will be published at the start of December, which will pronounce on local government reform. I think that will have potentially significant implications for both Essex and Suffolk. And so we'll be very interested to see what that means once the paper is published. Thank you, Chair.
Ed, thank you very, very much, and thank you for all that great news. Well done to the team, and particularly well done on everybody, all team members, on the productivity increase. Nick, thank you very much to ESNEF, but also contributions from all partners around the system. So really, really good news. Any questions? Yes, Fanwell.
Thank you, Chair, and thank you, Ed. More comment than a question. It's about the Tooks bakery site. That I think you all remember that there's been, various proposals over the years, which have, unfortunately, haven't materialized. And with a new estate sort of coming up in that area, I think there is going to be increasing pressure as well on that. And now, when this was announced, there was quite a lot of disappointment in terms of the public, and I'm glad that we're talking about a new plan for that, and hopefully, when everything is ready, it will be good for us to communicate with the public what that looks like, because at the moment, I think there is a little bit of discomfort in terms of the pressures that might come with.
Thank you. Do you want to respond to that, Ed?
Just agree with what you're saying. It's incredibly disappointing for that community. We're very disappointed too. We want to make it good.
Yeah, noted. Thank you. Helene?
Yes, I wanted to refer to the orthopaedic centre opening. So it's usually really good news to hear that. I'm just thinking back to the board meeting we had in July, where we had a really good presentation from Healthwatch, who did a survey of the population and talked about some positive feedback, but also some concerns that were raised. And in that meeting, I think we talked about hearing the follow-up to addressing that in a future meeting. So just really to raise it to see if we have got any feedback yet from addressing the Healthwatch survey, if that's going to be covered today or perhaps in a future meeting.
Let me go to Ed first, and then Nick, if you need to come in, please do. Go on, Ed.
Yeah, I think a report, looking at Peter, as a report planned for January on the Healthwatch report. So I think that's scheduled, but maybe you might have any more information. I don't know.
Go on, Peter.
Yeah, so we discussed this at the West Suffolk Alliance Committee, and when we've looked at the numbers, we think there are existing options under national rules that relate to financial hardship and relate to specific clinical circumstances where someone needs a carer. And so our proposition is to apply those principles in transport support, like we do for other treatment options for patients at the moment, and then keep it under review after 6 months, remembering that patients will always, this is a choice, ultimately patients will have a choice if they're in West Suffolk to continue to go to West Suffolk Hospital Trust. So that's our approach, because until we've actually been running it for a while, it'll be difficult to know the exact numbers that are involved, and we're careful not to set a precedent. So that's where we concluded in the round discussing, and we'll be bringing that to Suffolk scrutiny in January.
So a more formal update on that, informal update in January, still scheduled?
Sorry, a formal update.
So I think the point that you were looking for was a more formal response to, was it not, Elaine?
Yes, so I recall at the meeting we said there would be an update to the board just to go through how the concerns were being addressed. However, that was seen as appropriate, and so it's just really the feedback still coming here.
So should we schedule that for January, Peter, and we can discuss outside the meeting or you can discuss exactly how you do that. But let's put it on the forward plan for January. Tom, happy with that? Yeah. Did you want to add anything, Nick, or is good? Wonderful. Okay, thank you. Any other questions for Ed? Otherwise, we're asked as a board to receive a note. Noted. Thank you very much. In which case, item 7, Peter, I'm sticking with you for dental commissioning plan update and progress. Over to you.
Okay, thank you. So this is the second update that we've given. We brought the dental plan in March as a 3-year programme to try to turn around the oral health in Suffolk and North East Essex. And this paper sets out the progress and challenges that we've made so far. I've put a sort of an executive summary at the top, and then there's a lot of detail below, but just to talk the board through some of the headlines. We are implementing a new quality approach in terms of the governance of quality, because we have over 150 providers, and to get a proportionate approach to the quality of care and supporting practices and patients with the quality of care that's being provided. We are developing a workforce strategy, working with dental community and the universities in terms of the way forward, but we're taking some very successful practical steps in the short term. In the primary care careers, as we've done with general practice, we've had 4 dental surgeries who've put vacancies onto a large platform to help anyone who's looking for a dental role in Suffolk and North East Essex. Those 14 practices now come up, and we've already had 4 staff recruited through that process, and so we're looking to extend that further. And we're also there's a national incentive scheme for new dentists working in the NHS for the area, and we've been successful in supporting practices with that to date. And we're just starting some work with therapists, which is the new dental workforce that can do so much of the treatment, to think about how we can, when all the graduates coming out, how we can cement their place in the NHS dental workforce of the future. The vast majority of oral health problems can be prevented through great oral health practice that all of us and individuals and every member of the population can have an eye on. And we're trying to also think about what we can do to further support that. And so we've done a really significant survey of all of the partners involved who could contribute to prevention and building those views into our prevention strategy. In the meantime, with our 2 county councils, we've identified the young children and early years settings with the greatest deprivation, high school meal, free school meal numbers, to look at what targeted support we can do with regards to supervised toothbrushing. And in Essex, we've got, as a really successful oral health champions training program, where 85 young people are spreading the good, what great oral health looks like and how to do it with their peers. That's a really important area for us to work to improve on. As colleagues will remember, with our health inequalities, this is one of the areas where the postcode you live in has a big difference with regards to your oral health, and particularly in parts of North East Essex, where we're conscious that we've got so much further to go to improve children's oral health. One of the programs that we prioritised at the start of our first year was a dental priority access stabilisation service, and we have contracts with 19 practices on a sessional basis, the amount of time they put in, not the number of quantity of work they do, which is different to the national contract. And we ask them to look after urgent cases and people of particular characteristics with high dental risk. And that service has been really successful, and it's stabilised at around 800, 900 appointments per month. And we've got a quote in the paper from NHS 111 saying what a difference this service has made. They've got a really good option for patients now with an urgent dental problem presenting to them in one of these 19 practices that's distributed around Suffolk and North East Essex. We've also working with one of our community dental services in Suffolk to set up a mobile service that's very targeted for children and young people, in particular care homes and targeted areas, to offer prevention and treatment service for those groups where we identified there was a gap. With regards to general dental access, this is a massive challenge for us, and I think we're making some good progress, but there are some pretty tough headwinds that we are working with. But we're pleased to report that we've seen 7.8% as of October, like-for-like growth in units of dental activity, which is an imperfect measure of dental workload, but it's a measure that we have. What I think is more helpful to count is the number of people who've accessed NHS care, and we've seen a 5.4% increase in the number of children who've been able to get an NHS appointment. We have some of our practices are looking to offer extra NHS workload, and we've been able to commission around 53,000 extra units of dental activity with those practices. But equally, some practices saying, this offer doesn't work for me, so I'm handing you back 24,000. So I think that those statistics help illustrate the kind of 2 steps forward, 1 step back nature of general dental access that we are working with. We've reviewed the access across our area and identified in the paper particular geographical areas where dental NHS need is we're not meeting it as well as we might in terms of distances patients need to travel. And so we'll be prioritising those in a procurement plan approach that we're taking. But we're seeing some green shoots of improving access with regards to there's a website that you can use to find your nearest NHS dentist. And if a provider feels they're able to offer dental appointments, then they will declare themselves available on that website. And there's between 10 and 20 practices over November have been declaring ability to offer NHS services to patients. And that includes the new centre in Ipswich, the community interest company run by University of Suffolk, where they've got their recruitment levels to a degree where they, as well as seeing the vulnerable patients as part of the equivalent to the DPAS programme, they're also offering general dental access to patients that are contacting them. And for some, that includes general care, but it also, because they have the skills in that team, offering some of the more specialist procedures. But that's just one part of our plan for general dental access. Orthodontics is also a really important component, and we've got lots of work to do in oral maxillofacial surgery in Suffolk and North East Essex, but I think the orthodontics pathway is a key component of that, and we had some handbacks from 2 providers, and we've recommissioned those with 2 other surgeries. We've also been able to commission 9,000 extra units of activity, and we're working with our 2 orthodontic clinical leads to come up with a commissioning plan, a more long-term commissioning plan to commission services from our orthodontic professionals. We also commissioned our 2 community dental services, and we identified that in Suffolk, that the service was below the level being offered in North East Essex for people with dementia and learning disability and autism, and so we've commissioned more sessions that start in January from the services. There's lots more detail in the paper, and I'd be happy to answer any questions. And just to let the board know, we've, I think, agreed as an executive that we'd bring this update through our normal performance routes now. This will be the last time we'll bring this particular report to this board, but hope that gives a good description of where we're up to. Thank you.
Peter, thank you very much, and a lot of progress on, good progress on numerous items there. Still work to do, of course, and as there always will be. So questions, first of all, I've got Elaine first, then Fanwell, then Ed. So Elaine.
Okay, thank you. So really good to hear the progress, and particularly the last meeting, I remember asking about if people could get access to an NHS dentist, which I know we talked about. So it's really good to see the evidence that that's actually coming through, that people are doing that. And I did a little search in my own area, and actually I found there are more available. I suppose I still have a question. If people aren't able to get that, and there may still be some, what is the sort of fallback support for them if they do find that they're having dental problems? How can that be addressed?
Thanks, Elaine. I mean, I think we have to say we're still not able to offer the full NHS routine service for dental care that we'd like to. So I appreciate there'll be many people finding themselves in that situation. So our advice is to call NHS 111, and with the dental nurses on the call there, they will, if it's an urgent problem or the patients from a particular protected group that we're offering the service to, we direct them to the one of our 19 sort of high priority practices. So we'd recommend that if you're struggling, call NHS 111.
Okay, thank you, Elaine. Peter, Fanwell.
Thank you, Peter. I think it's said that we haven't really reached the sort of pre-COVID levels of access, but the positive thing is we are moving in the right direction. I just wanted to check on the prevention strategy that is being developed. The report talks about surveys being done with dental providers. Is there any intention to maybe come up with a mechanism to speak to service users and members of the public to help inform that plan as well?
Thanks, Fanwell. Yes, the survey has been really broad. So it's included dental providers, but it's also included all of our partner organisations and Health Watch and all of the public voices that we're able to speak to that have a dental interest. I mean, we haven't taken this out to the general public as a topic, but we're really working with the schools and with our councils and with Health Watch to ask them for their views. But that's something we can take away to think of what further we could do. We're also working really closely with the alliances, and we've got this really exciting project working with Ipswich Town Football Club to help promote some of these messages. So we're trying to weave the dental prevention story into the day-to-day work of the alliances, where all of these community contacts sit.
Yeah. Okay. Thank you, Fanwell. Ed.
Just in terms of commissioning going forward, Peter, so the DPAS scheme is based on sessions, not UDAs, i.e. it's preventative work rather than kind of filling and drilling, as they say. So I'd be really keen that we commission sessions as a principle going forward. It just seems to be the right thing for the community. How possible is that, and what sort of flexibilities do we have?
So I think there's a sort of Goldilocks spot of doing the right amount between too much sessional commissioning and too much activity-based commissioning. And in terms of, I think a mixed approach is what our dental providers are advising, where you might say have 20% of a contract, which is sessional basis, and linked to particular targets that are not based on activity, but then there's still an incentive in the contract to get through quantity of work. And I think that's part of what we're trying to work through to get the right balance in terms of the offers out to the community, because I think so if that helps answer your question. I mean, we can do, in intellectual terms, we can do whatever we like. The difficulty is the mechanics of doing this for across our population with as many providers as we have. So we're just trying to get our house in order a bit with the next commissioning offer. So we've got DPAS out there at the moment, but before we get out in the community with the procurements and other offers to contractors, we want to make sure we've got that right. But there's different models across England that we're looking at. In Manchester, have got a sort of a target base, a bit like an enhanced service reward model that they've got, that they're applying. And we're looking at that model, or looking at extending the DPAS in other ways.
Yeah, I mean, as ever, I'll leave the detail to you, but as long as we've got prevention built into the commissioning, I think, which is what you're saying, that would be good.
Yeah, thanks, Ed. Good question. Thank you for the response, Peter. And Tom, if we could note that in the minutes, that prevention built-in point, really, really important, both for this agenda and indeed for all. Let me go to Clement next, and then Frida.
Thank you, Peter. Really important to see the progress. Just wanted to touch on the support for people in care homes around dental and how we're looking to measure the impact in relation to that, to consider as a whole set of preventative measures and support for people who are in care settings generally. Would be really good for us to hear more about that.
Thank you. Yes, I mean there's two components to that. There's the oral health awareness of the care staff and their skills, and we had a sort of conversation here, I think last time we brought this item, to think, well, what could we do to help bring oral health to the front of every health and care professional's sort of skill set and consciousness in the care homes. We're looking at a scheme that Mid and South Essex have commissioned with regards to going into care homes to provide enhanced services. We need to resource that in people terms to see the impact, but that's another area that we're looking at. So I think those are the two sort of interventions. It's difficult to, unless we're doing detailed surveys, to look at the impact on individual resident groups. So hence we're focusing more on the interventions.
Okay, Clement, with that, thank you. Kath, is yours on this subject? Yes, but on that specific point that Clement raised. No, in which case I'll stick with Frida and then I'll come to you if that's okay.
You. Hi, Peter. Yeah, great progress from like virtually nothing to this is really good, because I go back to when there was very little, obviously, in our area, particularly in tendering. But just Clement brought up my idea about my question about care homes, but domiciliary services to people who are housebound would be something that would be considered. I know other areas do that. They have domiciliary dental visits. I know that's like, but I visit people who are housebound, their dental health is pretty bad and they don't get dentists coming. So that's one idea. But the other thing is about orthodontics. It's still quite low. In terms of your figures on the table, compared to 2017, 2018, a number of appointments available. So I think parents tend to be really concerned about 2-3 year wait for orthodontics for their children, and often they wait to about 15. The child is about 15, 16, which can be quite late, particularly in oral health when they've got twisted teeth, and that's worse for their gums. And the other thing I was going to say is it'd be really good if, in terms of the umbrella of primary care, including dentistry, general practice, etc., that we could perhaps do something in terms of education together, because it's not just about dental care versus overall health. Does that make sense? It's about a combined approach, it's the whole health, the kind of holistic approach. And I wonder if, because dentistry has always been so separate to general practice, but actually I don't see why, because especially when you go on about the children's education is so important. And I think we could do something in terms of combining that in terms of general health education.
Peter, you're nodding. Are you saying yes to?
I think we're really supportive of that, and any ideas and efforts to how we can bring particular dental and GP communities and primary care communities to think about a town-focused approach or local approach around health messages would be would be really strong. And we're conscious we've got, Clacton in particular, working with those providers, we've still got some way to go in terms of getting our NHS volumes up, but we're hopeful about what's around the corner, but perhaps we pick up outside. I think the thing with this is to try to be as targeted as we can, because the number of things we could do is a very long list. So it's just trying to pick up on those areas, and we're conscious that for the Clacton part of North East Essex, it's perhaps an area where we've got this a difference that we perhaps should be focusing some of our next actions in particular on those areas.
Thank you, Peter. Ed, did you want to come in there?
Well, just linking with the PCN test sites, where we're encouraged to be innovative, and you're leading the tendering PCN. I mean, if there was appetite for discussion around dentistry and general practice coming together, it would be a perfect site, I think, to test something. So
yeah, it'd be a great intervention in terms of the pilot scheme to do a project like that.
Yeah, sounds like a great idea. Should we take that as an action outside the meeting between, Peter, would you lead on that to make sure that happens? Right. Yeah, thank you. And Elaine, is it on this subject? Go on then.
Yeah, I mean, I was just going to agree. I think that's a really good idea. And just thinking the alliance structure kind of might be the right way to sort of filter through it, but maybe starting with Peter in the West Suffolk Alliance area, and then seeing if it's something that can be explored through the other alliances. Sounds like a good way to do it.
Okay, sounds like you've got a little group ready forming, Peter, we'll leave the action with you though, if that's okay. Kath.
Thank you. I appreciate this is a ginormous ask for us all across the system. I liaised with our lead in learning disabilities and autistic services within NSFT, and they had a meeting with their experts by experience, and they're still struggling to access dental services. And we know people with learning disabilities and some autistic people who can't articulate pain, it actually has really disproportionate effects on their life and can end up escalating. So I'm just wondering whether we outside the room need to have a conversation about how we can think more from an equitable perspective for targeting learning disabilities and autistic people and making sure those services are truly accessible to them.
Yeah, go on, Peter. Should I just go to Andrew first, and then you can collate your answer, Andrew?
Well, I'm just minded we've got health checks for learning disability and people with SMI, but they don't extend to dental health, and that's maybe something we could implement locally.
Peter. Yeah, thank you, Andrew. Peter?
Yeah, so this is a population we've really tried to prioritise in the sort of first year. So we've commissioned these extra services. So I think you're right. The next step is really to get in front of those the voices of those communities to be saying, so what's it like then? What is and isn't working? And that's perhaps something we could take away to work with NSFT colleagues and ICB colleagues to think about, going in and listening to see, well, so how is it working then?
I would say social care, because actually there's a large number of people in the community that don't necessarily interact with health acute services, but with social care, hugely so. So how are the care providers supporting people to be able to access those services or struggling?
Okay, so thank you everybody for that really rich debate. I think we all agreed great progress, and we're asked to note the report as a board. We note the progress. Actually, I think that was a really great and value-added discussion from the point of view of equity and access, and the issues that you've now raised in actually taking this forward to the next step. So we've got a bunch of actions. Peter, I think we're going to ask you to continue to lead on that for us, and perhaps it'll figure in the matters arising action log, but update us at the next meeting how those developments have proceeded. Okay, everybody happy? All done? Great, thank you very much. In which case, let's move on to item 8, which is the Res and Des paper. I'm going to start with Amanda, but then I think, Amanda, you're going to hand over to Andrew to run the item, so all yours.
Thank you very much, Chair. So our Race Equality Standard and Disability Equality Standard are important initiatives aimed at promoting equality and inclusivity within the workforce. Development and attention in these areas reflects a commitment to addressing disparities and ensuring that all staff, regardless of race or disability, have equal opportunities to thrive. Our reporting shows that representation and experiences of minority groups differ from other groups in some circumstances. We must ensure, by continuously monitoring and implementing our strategies based on our race and disability findings, that our ICB not only enhances employee satisfaction for everybody, but also improves our services through a diverse and empowered workforce. Appended to this report, Appendix 3, you will see our EDI action plan, which is being co-produced by our staff networks. And through that action plan, we are bringing to life the findings of both the RES and the DES report, but also the actions that underpin so that we as a board can monitor and track our progress as we move forward. Before we invite Tina and Lisa to bring to life the action plan, I'm going to pass over to Andrew, who is our current EDI steering group chair. Thank you.
Thank you, Amanda. I'm just going to bring this to life a little bit before we bring Tina and Lisa in. And before I do that, I was really reminded today at the beginning of the session about what reasonable adjustments mean in day-to-day life for people with different mobility issues. If you can't come up steps and you have to use a different way of getting into the building, your access to this room is through a store cupboard piled with chairs and other equipment. You have to battle through a door that doesn't open properly because there's a cable in the way and you can't access the whole room. Now that is a shared societal problem. That's not necessarily an NHS problem, but that's our starting point. And I think it's worth just remembering that. This is probably the most important paper we'll talk about today. So we've got 15 minutes to hear from some people with lived experience of working with protected characteristics, but also some opportunity for the board to ask questions and make comments on what we're going to talk about today. I want to draw out some key data from the report. It's there and I will take it as read, but just some things I think are worth drawing out. So if you're a white member of staff in our organisation, you're 3 times more likely to be appointed than if you're a BME member of staff. If you're white, you're 33% more likely to have non-mandatory training opportunities. If you're white, you're 50% less likely than BME staff to face bullying and harassment from the public, and 33% less likely to face bullying and harassment from staff. And BME staff are 200% more likely to face discrimination from a colleague. And none of the executive voting board members are from a BME background. Moving on to people with disabilities. So non-disabled members of staff are 2 times more likely to be appointed to a role in this organisation. Disabled members of staff are 100%, in fact more than 100% more likely to face bullying and harassment from the public, 300% more likely to face bullying and harassment from a manager, and more than 200% more likely to face bullying and harassment from a colleague. 300% more people with a disability feel pressure to come to work from their manager, and none of the voting executive board members have a disability stated. So the action plan that we've produced co-produced with members of staff is not perfect, but it does try and tackle this problem in 3 different ways, through structures and policy, through training and development, but also through representation. I think what we need to agree today is how we're going to come back to this and how we're going to assess our progress against this action plan, rather than fall into the trap of many organisations and repeat the same action plan year after year without ever addressing whether actually it works or not. I want to just give you some just some quotes from a paper that recently published. So on the 1st of October, Roger Klein published his analysis of the progress of the NHS in BMJ Leader. And I'll come to his conclusion in a second, but 2 quotes that really stuck out at me. Sustainable change in any aspect of workforce culture requires clarity of the problem to be solved and a credible theory of change underpinned by relevant peer-reviewed evidence. And I think that's something that I have to take on board as chair of the EDI steering group and as executive sponsor for EDI in the organisation, as whether we're actually doing that, because I'm not convinced we're doing that as much as we could do. There's also a definition of the problem, which is the collective failure of an organisation to provide an appropriate and professional service to people because of their colour, culture or ethnic origin. It can be seen or detected in processes, attitudes and behaviour which amount to discrimination through unwitting prejudice, ignorance, thoughtlessness and racist stereotyping which disadvantage minority ethnic people. And then finally, Roger Klein's conclusion was, in 2014, after publication of the Snowy White Peaks, this is in Roger's voice, I met a group of nurse managers who told me they'd advised their children not to follow them into nursing due to their own treatment. We will know we're above the foothills of the Snowy White Peaks when such managers do encourage their children to join the NHS. A decade on, there is some welcome progress, but the NHS is still on the foothills of those peaks. So I'm going to pass over now to Tina, who is one of our network chairs, who's going to give you a couple of minutes of her thoughts, followed by Lisa.
Thank you everybody for this opportunity today. I come to you wearing 3 hats today. I'm a person of lived experience of a disability for over 40 years. I'm also a co-chair and I'm also a long-standing member of the NHS employer. So how can I summarise all of this for you to make it impactful for you today? And I simply want to say this to you. Disabled people and people with a long-term condition are still expected to fit into a working environment and a working culture that is not adaptable to them. Discrimination, bullying, harassment therefore become the default. Disabled people are not allowed to thrive. We become the forgotten cohort of communities and the forgotten cohort of staff. As chair, I am passionate about making this change because the next cohort are just behind me. And what legacy do we want to leave for them? I will leave you with this if I may. The irony is that disability does not discriminate. Anyone in this room, anyone watching from home will become disabled or be affected by disability at some point in their lives. If it isn't something that you want to accept for yourselves, then why are we accepting it for others? Be the change. It's a pleasure to be around the table today. This is a sign of things to come. Long may it continue. Thank you.
Thank you.
Okay, and I'm co-chair of the REACH network. Looking at the RES report, some of the things that jumped out to me was the population within SNE. Is it equal to the population that we look after? I don't know, because the numbers are not there for me to see. If it is, we're doing something a bit positive, but if it's not, we have a lot of work to do. And as Andrew said earlier, when I look at the executive board, the people that I work with every day, the people that I reach out to, they don't look like me. And it's not that you don't trust the people, but there is greater understanding that the person I'm speaking to probably have a lived experience. They probably experienced some of the discrimination, some of the health things that I've experienced, and it's easy to disclose things a bit easier to people that look like you. And I think we need to work on that. And just looking at the data where it's harder for me to progress. Why is that? Why am I not being helped to progress and to get to the place where I need to be so that I can be on the exec board if I want to be there, so that people can say, oh, Lisa's done it, I can do it too. So it's how do we do this? How do we work together? And what I can tell you, people that look like me don't like things being done to them. They want to be part of it. So with all the networks that we have, it's the same thing. We cannot make the change unless we're in it, and our voices need to be heard so that we all can move together in that place. And when it happens within our organization, it will spill out into the community. Thank you.
Thank you, Lisa. Thank you, Tina. Happy to take questions.
Thank you, Lisa and Tina. And well said, passionately said, but also said in the right place to the right group of people. So let's see what the responses of board members are like. I'll start with Kath, then I'll go to Nick.
Thank you so much. Yesterday, NSFT, we had a board development day, and Yvonne Coghill, who was part of setting up the whole race equality standards programme about 5 years or so ago, came because she's working with us on this. And within NSFT, she's done a lot of focused interviews with colleagues across the organisation, and key themes that came out regarding race relates to nepotism. So if you look like somebody or you don't look like somebody, there's a greater perception and likelihood that you won't progress in your career. A real feeling of unfairness, lack of progression opportunities, that nobody listens. There's a lack of understanding about the race agenda, and I would argue that applies very much to disability as well. And that there is, we are ignoring discrimination and racism within our organisation. I would also argue that that just doesn't apply to NSFT. I think we are Norfolk and Suffolk, and obviously Suffolk North East Essex is a predominantly white population, and we are living in a population where our workforce doesn't necessarily represent the demographics of our colleagues. And I think this is, every single organisation will have their own res and des reports and plans, but actually this is I think a systemic issue that we need to be working together on. So of course we have our own individual organisations programme, but there is significant overlap, and we should be using each other and working together, because our patients, our service users and our staff don't always just align to single organisations. So I commend the report, support the network's voices, but I think we need to see this as a major priority. There's an economic case for it, there's a moral case for it, and there's a clinical outcomes case for doing the right thing here for our staff and therefore our populations. And these behaviours translate into discrimination towards our service users. Thank you.
Thank you, Kath. Well said. And opportunities for learning across the system, of course, but so many reasons why this needs to be done. Thank you. Nick?
Thank you, and thank you so much for sharing this morning. Very powerful. Thank you for that. And I agree with Andrew, this is the most important discussion document today. And really, it was just to, Kath stole my thunder a little bit there, is that this isn't an issue that sits within an organisation. It's not a system that sits within the system. It's a system. It's an issue that sits within society. And so I'm wondering, the power of bringing all of our work together under the auspices of the ICB. There's lots of work going on in pockets. It's probably similar, and there will be some similarities, but there'll also be some differences in approach, because we're listening to different voices and hopefully hearing and then listening to different voices. I also think there's a very, and I spoke about this some years ago, there's a very powerful message that we as system leaders and as therefore community leaders can make about the intolerance that we should be showing to members of the public who, for whatever reason, choose to behave in a way that makes people feel threatened, makes people feel scared, or is in any way discriminatory. So I think we do have that responsibility. Between the organisations that we represent, we touch the lives of tens of thousands of people every single day. And the message that we send from this board and from our individual boards, I think, is strong. The message we could send collectively of all of our boards together under the auspices of the ICB, I think, will be even stronger. Thank you, Chair.
Thank you, Nick. Well said. Fanwell?
Thank you, Chair, and thank you very much for the report. I think we'll all agree, as we have heard already, that this is a very important subject. Not because we just want to bring everyone in, but there is, as you have said, Kath, an economic benefit to this. I mean, we're also noticing in organizations a lot of presentism, a lot of legal challenges as well in terms of getting this wrong. I think one of the things that is frustrating is, we've talked about this for a long time, and everyone seems to agree that, we need to get this right. When I look at some of the, indicators on the percentage of, staff from minority ethnic backgrounds experiencing harassment and bullying is doubled between 22 and 23. I think it's really important that, we're very clear in terms of what the actions we're going to put in place to address that. Firstly, in terms of ensuring that colleagues feel that when things like that happen, they will be supported. But also on the other side, how are we dealing with, our patients and public who are also perpetrating, these things? When I look at the action plan, it mentions a lot, some of the actions that are going to be done by, human resources, which is the right place for that. But how are we ensuring that colleagues across the system are also taking ownership of the problem, where these things are happening, as opposed to delegating this to HR? Thank you.
Thank you, Fanwell. Janet?
Thank you very much, Chair, and I agree with everything that people are saying. And this is, looking back to some of the ICS work, this is one of our biggest uncomfortable truths, I think, in our system. So it sort of links into that. I'm sitting here very uncomfortable and find it very difficult to read some of this around things that are happening to staff in our organisation. Discrimination from managers, team leaders, colleagues, and then pressure to come to work for disability. Those are the people that work in our organisation doing those things. So we need to be really sure that we have sound HR policies and our freedom to speak up arrangements that make people confident to speak up, because we cannot change these things unless we know about them. So I did wonder, is this consistent with things that we knew about through freedom to speak up, or things that we knew about through HR policies and whistleblowing and all of that? Because if it's not something that we're aware of, we need to do something fundamental.
And I'll perhaps come to Amanda to respond to that, if I may. But Janet, when you said you found it difficult to read, that's because, not because you don't believe it, but because we won't tolerate it. So, and that is a sentiment that I think the whole board is adopting. Sorry, Amanda, Lisa, did you want to come in there?
Yes, thank you. On the freedom to speak up, but that's a positive thing that we've done as an organisation. We have a place to go, but based on experience, people don't want to use that service. One, they feel, well, if I want to continue working with the NHS and I say something, it may follow me. Although we've been told it's confidential, they're still afraid. People like nurses, pharmacists, anybody with a PIN, don't want to do it, because even if I go to Lancashire, that may follow me, because your world becomes smaller. And as far as I know, HR is not getting those responses. It's coming out in the private survey, and we need to do something about it because it's happening. When I joined the CCG at the time, I was told at times, just keep your head down. And I think we need to get people to stop keeping their head down. If I'm kicking Tina, Sarah's here. Lisa, what are you doing? That's what I want. That's what I want us to be like. And I think once we start doing this, we will see so much change. Sorry, Amanda, I just feel like
you're okay, Lisa, don't worry. And no, I think we're all buying into that. No heads down. And, you know, a philosophy that we've often discussed between ourselves over difficult issues: do the right thing. So let me just get, Amanda, did you want to respond on that issue? And then, Kath, I'll add you to the list if I'm...
Thank you, Chair. So picking up Janet's points, which I completely agree with, I think there's 3 comments I would want to share. In terms of freedom to speak up, as we know, we have now independent freedom to speak up in place, and we've had a contract with the Guardian Service spanning the last 12 months. During that period of time, we've had less than 10 cases that have come to fruition and obviously actioned accordingly. And to my knowledge, no EDI issues in its broadest sense have been raised in that regard. So that was my first comment. In terms of my 2 other comments, one was around the annual staff survey, and of course, the broader EDI issues are picked up in granular detail, and we do our very best as an organisation to manage those appropriately and try and act on what our workforce are sharing and more. In terms of HR policy, yes, we have those in place, and they are pretty up to date, I would suggest, and embedded. HR will deal with any cases that is brought to our attention. What we can't deal with is the unknowns, and I think that's something that perhaps we need to be working harder on, and that's something that I can take forward. My final point was around induction, and partly to your point, Lisa, we do have monthly induction for all of our new starters every month, and we do cover the broader EDI agenda to give that general enhanced awareness too. But I acknowledge everything that's been said, and we have more opportunities to enhance and work with our staff accordingly.
Okay, thank you. Let me just go to Tina, but then I'll do a bit of meeting management because I've got a long list of initials here. We'll just check and then we'll see if we can wrap. So, Tina.
Thank you. Just going on from Lisa's point and Amanda's, I think the big thing is psychological safety. Staff, employers, they need to feel psychologically safe to come forward. It isn't just about reasonable adjustments in isolation. It's more than one thing. It's part of the bigger culture shift. We've got a real opportunity now within Suffolk and North East Essex to lead by example. Yes, we're on par with national average, but that's not good enough. Let's take this opportunity now so that next time when we come back, we can tell you what we're doing is working and we're seeing it in the figures. Because if we don't, my concern as a person with lived experience and as a professional is that these figures will not change and they will continue to get worse. And that will impact not only staff, but our communities as well. Thank you.
Thank you. Let me just do a bit of management. So I've got at the moment, in the order that they were flagged, or at least I wrote them down anyway, I've got Susanna, Elaine, Chris, Pete, and then Kath and Frida. And then I'm going to ask Ed to have a go at wrapping it, Ed, as well, with your comments. So now, is there anybody else? Otherwise, we're going to get into time challenge issues. So subject to somebody waving energetically. Oh, are you? Okay, Dave, that would be excellent. Right, let me start with Susanna.
Okay, so first of all, thank you, Lisa and Tina. And personally, I think that we really need the freedom to speak up through in any place that we are on these issues, and that's where we need to get to. I wanted to build on Kath and Nick's points around the need for this to be a board assistant conversation. We have begun that. We began it through the work around uncomfortable truths, which I think was helpful in terms of moving the agenda forward to one around injustice, and also absolutely for our staff, but also for our people and communities. And, you know, the depth of that conversation really, I think, hit all of us very, very hard. And the output from that was a sort of distillation of 22 things, which I'm going to update the board a bit later on under the ICP update. We've just completed a first self-assessment across quite a large number of ICP partners around, but that is the absolute bare minimum, absolute bare minimum. I think it was really welcome that this board did the cultural psychological safety training. I'd like to see that for all staff in the ICB. I think that, you know, that would be a real commitment in terms of creating that environment in which everyone can speak up. And the other thing I'd like is partners' commitment to continuing that conversation around uncomfortable truths. I think we could take that further. I think we could build on the very, you know, the huge bravery that so many people showed in terms of starting that conversation, but we need to carry it on.
Thank you, Susanna. Elaine?
Yes, so I think thank you for bringing to life this topic. The numbers look really shocking. What is in terms of the disparity, and what's been really good today is just sharing your personal experience. A couple of things that came out to me though when you were speaking in the discussion, Lisa, I really liked your point about that if we get this right and there's an opportunity, the opportunity to spill that into the community is there. So it's almost like we have got the opportunity to do that here. And then actually one of the things I was also thinking about was just this time at which we take to look at this. It's like once a year, it's a report that's done. The frequency with which we get sense checks whether any progress has been made is something that strikes me we don't really have. And I do wonder if there's something about perhaps just having smaller kind of checks that are done, and you might have some ideas how you can maybe do that, but smaller checks that are done more frequently, that actually we're starting to move in the right direction, rather than it's a kind of once a year report that's done that doesn't, you know, that then we suddenly all realise how shocking and we've not made the progress we expected to. So it's just my reflection, but thank you both for sharing it today.
Thank you, Elaine. Chris?
Thank you. Thank you for that report. It's really illuminating as to how you feel, and you brought it to life. I can speak from lived experience. I've gone through the similar experiences throughout my career. But I'm very encouraged that we are discussing this at this board level and the importance that we are giving it to. I must also admit that when I came to the staff meeting a couple of weeks ago, there was not much diversity in the room. There were about 400 people in the room, but there was not much diversity. So I just want to know whether there's any positive measures that we are doing to encourage. I do accept that it is a predominantly population, a white population area, but are we doing anything particular to address that?
Thank you, Chris. And Amanda, I saw you nodding, but perhaps I'll come to you at the end, and it might well be, I'm not trying to tell you what the answer is here, by the way, but I'm just wondering whether we actually need to receive a future report and an update report that, that emphasises the importance of this and the discussion we've had, and that might be a way forward, but I'll leave that with you to think through. Pete. Is your microphone on, Pete?
I want to thank you. Thank you very much for bringing this paper. I think I would want to endorse what Susanna and Nick have said about approaching this as a system. I think a lot of this sits in a societal context. We can't underestimate the importance of culture here. I think, Andrew, you mentioned being relentless in the way that we take this through, and I suppose my challenge would be that everything that we do needs to have an equality, diversity, inclusion lens all over it, including our populations and our workforce. So I think that that's really important. In Essex County Council, we've been doing quite a lot of work on this with our quests, looking at intersectionality as well as race and social graces in terms of the impact of multiple protected characteristics on your prospect. So again, I think reaching out maybe to our HR leads as well to talk about, well, what we've done in Essex County Council in relation to some of this work might be an opportunity for us to think about as a sector where the learning is and where the impact might be showing itself.
Yeah, system approach. Thank you, Pete. Kath?
Yeah, thank you. One of the most powerful things I heard amongst all of this, Lisa, is when you said the words are keep your head down, and the risk of this following you through your career. And then also link into the freedom to speak up conversation. We're putting the onus on the individuals experiencing discrimination to raise those concerns. My view is that we as leaders need to keep our heads up and be really looking for this and not putting the onus. So the people who even filled out a survey of a small organisation are potentially at risk of identification. And we're asking the people who are experiencing this discrimination potentially to put themselves forward to tell us what's going on. We now know we don't need to keep asking all of the time. We actually need to be looking and acting proactively. So again, I take this in our leadership role, not just as members of this board, but leaders in all of our organisations, is we need to have our heads raised and not put it in the responsibility of the people who are experiencing this discrimination.
Thank you, Kath. Well said. Let me then go to Frida, and then what I'll do is, Amanda, if I come to you for some comments, I'll then go to Ed for Ed's wrap on this one. So, Frida?
Yeah, I just want to thank Tina and Lisa. And Lisa, I'm really proud of you as a friend, actually, for all the work you've done and always have been. But I am also a woman and Pakistani by origin and born here. And I'd just like to broaden it a little bit in terms of the politics of this country and going further into Europe and globally and the right-wing trend that we see. And as an Asian woman, as Lisa will be able to relate to, the more you see of this trend, the more you fear. And the more normalised people come and how empowered people become to make discriminatory comments when the trend is towards right-wing politics. And I've seen it all my life in this country, that as soon as you have a trend towards the right wing, which we have at the moment, and particularly in young males, which is really frightening, young white males, that I start feeling more fear, as do my brother and my sister, and I can relate to episodes like 9/11 when my people I know got beaten or spewed insults at just for their colour. So we have this trend again happening, and we can't get away from the politics of this and what that does to our workforce, because they go quieter, don't they, Lisa? We all shut down when we see the politics trend against us, and that's happening at the moment, which makes this so much more important, because it looks as an indefinite time that we are going to face now as people of colour and disability. But I think it's so important that we recognise that how much this affects us as people of colour, what happens globally in the political scenario, and how that makes us feel really vulnerable. and fearful to come forward. And it's more unlikely to come forward when you have a society that is led by politicians that think it or say the things so freely that they say. And I come from a constituency which there is a lot of that kind of talk, and I've lived in that constituency for 20 years and worked in it for 25. I no longer live there, and that's partly why I moved. But I have to say the trend towards that kind of enablement of the population is really deeply affecting for the people that work in it.
Okay, thank you, Frida. And leadership challenge for us all here. Dave's question wasn't dealt with by others, so quick one from Dave and then to Amanda.
Not really a question, really comments, and yes, sorry, Chair, for extending the discussion a bit further. Really, it's clear that we need a system approach really for this culture change that's needed. And when we're considering the system, can we please also consider our various providers, like our general practice, our dentistry, our optometry, and how we're going to involve them, engage them in this topic, but also to influence change moving forward. I think building on that, Amanda, one about the freedom to speak up guardianship that we've currently got in the ICB, whether there are ways of extending that out to our other providers, where I think the freedom to speak up is not quite as effective as we would like it to be, particularly within primary care. And then the final comment is about the usefulness of active bystander training. It's something that I've attended that it was so powerful, and whether that's something that we as an ICB could then commit to to offer to all of our staff and our providers out there. That actually this could be something really, really important. Thank you.
Dave, thank you. So, Amanda, any thoughts?
Yeah, thank you very much. So I've captured, I think, 6 key areas that I want to play back. So in no particular order, I think I'm going to start with your points, Dave. In terms of the bystanding training, we have in the last 8 weeks actually rolled that out amongst the ICB, but also primary care. And we've had good attendance in response to that, which was led by our training hub. So that I think is a positive going forward. In terms of our freedom to speak up, as I said, we currently have in place a contract that is being reviewed, and we're looking at how we can extend and enhance and reach into primary care, which is a must do from next April. So work is in place to make that effective. And then picking up Pete's earlier point around what Essex have done around Quest. About 2 years ago, when we discussed I think we just were newly appointed as an ICB board, we did reach out to Quest, and our EDI group at the time did receive some really great training. But I think one of the actions I'll take from today is to revisit and enhance and see what opportunities we have to cement further within our plans and organisation. I agree with Susanna's point around the broader system conversation, and I know we'll hear more about the uncomfortable truths and the 22 action point plan a bit later on. But I think an action we can take is to really extend the uncomfortable truth, the cultural safety and training throughout the ICB. So I think that's a quick win that we can take from today. In terms of the frequency of reporting, whilst we have an annual statutory requirement to publish, there's nothing stopping us from locally agreeing that actually we'll do it more than once a year. And I think that's within our gift, and I would suggest we do that. In terms of Chris's point around positive recruitment, I would agree, more we can do and should do. And I think there's something around moving away from our traditional recruitment methods and looking at how we can enhance and go into the more hard to reach areas and the like. So again, that's another quick win I would suggest. And regular reporting, I think it's something that we can commit to and bring back to the board. Frequency to be agreed, but I would suggest at least maybe 6 monthly or indeed quarterly. So that's something that we should debate. And I think all of this, I think we should wrap up and make more explicit where we can within the action plan, which is appended to today's report. So one action I would like to take is to, subject to board approval, revisit our current plan, work with our staff network leads and look at opportunities for further enhancement to pick up the rich conversation we've had today. So there would be my observations, Chair. Thank you.
Amanda, thank you very much. And Ed, just before I come to you, would it be appropriate if taking Amanda's last point about the action plan, if the board perhaps it's asked to approve the action plan as it is today, but received an update on it based on today's discussion in, say, 3 months' time. Would that work for you, Amanda, as well, in terms of delivery?
Very much so.
Yeah, okay. Over to you, Ed.
Thanks, Chair. I mean, thank you for speaking so bravely and so clearly. I mean, you landed all of your points very powerfully, Tina and Lisa. I agree with you, Janet, that the data's poor. It's uncomfortable, isn't it? It's not good enough. I think there's a host of actions that Amanda's described, and we can tighten up the governance around this. But one of the points you made, Lisa, is you might have an excellent freedom to speak up service in place, but if people are worried about consequences, it's not that excellent, is it? So we've got to think a little bit more broadly around this. We do have the vehicle of the uncomfortable truths to drive a systemic approach to it, but the uncomfortable truth is there's been varying commitment to it so far, hasn't there? And you'll talk about that later. So I think if we do want to work on the system as a system on it, and that's great, let's all commit to it properly and drive it forward. I think the final thing is just on networks. So the regular issue here is that the people that are disadvantaged shouldn't have the burden of leading networks to address that disadvantage. And I'm not clear whether that's happening in the ICB or not. And if it is happening, we need to revisit that, because it shouldn't be on you to address some of these challenges. So let's talk about that outside of the meeting.
Okay, thank you, Ed. So, board members, first of all, thank you to our speakers and your contributions. And I think it's fair to say that do correct me if I'm wrong, of course, that the board does not accept the position as it is today as the right position, and we want to see rapid and significant improvement. With that in mind, however, we're asked to receive the report as the record that it is, and approve it as the report pertinent to the time period referenced. And we're asked to approve the action plan. So subject to the fact that we also ask for the action plan to be updated and to receive further update and action plan in 3 months' time. Is that approved? Nods all round. Thank you very much. And then finally, shall we note that not only did the board not accept that the position as it is today is acceptable, that we recognise this is a leadership issue, and it's heads up, guys. Heads up into the leadership challenge. Agreed? Wonderful. Thank you very much. Thank you, colleagues. Thank you. Okay, so I think that might have sucked out the time that I was thinking of letting you have a coffee break during. So let's just see how we go now as we move on through the agenda. Let's move on to item 9, the combined ME and CFS paper. Narinda, you're going to be Richard for today, I believe.
I am. Thank you very much. Thank you. And thank you to Lisa and Tina. They've certainly set the bar high for me to follow. So thank you. So the paper is to propose the alignment for a combined myalgic and encephalomyelitis, chronic fatigue and long COVID service. So wanting to combine all of those service models together for a new service with the intention of commencing that model of care in the summer of 2025. This is quite an exciting proposition because we would be the first in the country to have such an aligned model, which would be consultant and GP with special interest led, a multidisciplinary service. So an exciting way of bringing those services together to support people. Why are we doing this? It's an opportunity, as you can see in the paper, that our contracts are expiring across multiple services that we have at the moment. Some of our services have got long waits, so there's inequity in terms of how people are accessing care. there are different service offers and arrangements. So the new model offers better service with expertise available to all. The Department of Health has stated that ME and CFS are a long-term condition and that we should align it in a similar approach as we have been doing across other services and with long COVID, which we've received funding for gratefully over the last 4 years. So combining those resources, we can improve access for all, for people with conditions that are multi-system conditions and similar. The ME Association, we've shared our service specification with, and they are supportive of the approach and have been complimentary of our service specification. So the aims are for her service to be a diagnosis, ongoing management, signposting to other appropriate services. You can see in the paper in section 4.3, this outlines the service offer. I think to note from the last meeting we had, the action was to improve our co-production and our engagement work, which we have, and we are immensely grateful to the generosity of local patient groups to help guide the changes moving forward. Co-production is going to be an ongoing part of this arrangement, and our lead around this, Sue Conker, has been working with Health Watch and some focus groups over the last few weeks. We also issued a survey on the Let's Talk SNE site, which we had 150 responses in a very short space of time. Amazing response. So a rich amount of feedback there that's helped us inform our service specification and changes. So I've said more focus groups going on in November to look at moving from current pathways to also, as we go forward, to perhaps mobilise the service. We'll have more engagement there, and we're gaining feedback from people that have got lived experience and are currently using our existing services. In terms of governance, we have taken the pathway and the paperwork through our ICS respiratory group, which is supportive, and also our SNE executive committee. So the proposal put to the meeting today is for a new model of care to reduce our wait, to increase our service offer to all, to combine those 3 service areas to improve the expertise and offer to everyone. It will improve connectivity with other services and move towards better integration and alignment for people of all ages. The expectation over time is that we can work with our existing chronic fatigue services for paediatrics as well, so bring those much more into that integrated model of care. Thank you.
Narinder, thank you very much. So, colleagues, this sounds to me like a great opportunity, and I'm thinking as well about our meeting management challenge this morning. Perhaps we could focus on if there are any reasons why we shouldn't do this, if you turn your mind in that direction. But I saw your hand up, Elaine, so over to you.
Yeah, so I did think this sounded like a great idea and a very sensible proposition is how it came across. So my question was more, are there or could there be any downsides or risks, which didn't really come out in the paper for me. So that was just really what I wanted to cover.
Yeah, no, good question, Elaine. Thank you. Narinder?
Thank you. I think it's quite complex to bring those service areas together, and it hasn't been done before. We accept that the conditions have similarities in terms of the therapists and the staff that you would want to use to support people, but there are differences as well. So we may need to make sure that what we offer is bespoke to the individual, which is obviously quite difficult when you're bringing a new service. But it's the right thing to do, I think, in the right direction, and it makes better use of the resources.
Okay, thank you. Howard, do you have a view here?
I mean, I just wanted to lend support, really, to say that, first of all. I think this is a really good example of how we're trying to work together to look at services across the piece as opposed to individual contracts. So we just need to do more of that, really. It's very good. Thank you.
Okay, thank you. So Frida, and then we'll see where we're going. Frida?
Yeah, I just think it's a really good idea to bring it together. I'm just a little bit concerned in terms of working with primary care, and so primary care is clear on its remit with this pathway, and it works with it. It will make it easier, without a doubt, hopefully for referrers into the service, into this service. But it's just about making sure those lines of connection are sort of together and working well.
Absolutely. If we didn't have this service, I think the people would have to be more supported in primary care. The idea is that it's the kind of mild to moderate patients that are supported in primary care, and this is really getting that diagnosis, supporting the severely affected in a much better way than we have done to date.
Noted. Good. Thanks, Frida. So, colleagues, we're asked to agree to the alignment and development of the ME and CFS long COVID services, and then to subsequently formally commission for SNE ICS a combined ME and CFS and long COVID service model from August 25. Are we agreeable to that direction of travel? Agreed? Lovely. Thank you very much. Thank you all. In which case, I'm then going to move us on to the ICB commissioning intentions. Howard, I think I'm going to you for this one. Is that right?
Yes, thank you, Chair. So I'll take this item in the absence of our Director of Strategy and Transformation. The document in the pack has been shared with our system partners and is written in the context of the refreshed joint forward plan, the strategic capital developments, including the elective orthopaedic centre, the new CDC in Newmarket, and of course the ongoing plans for the new hospital in West Suffolk. It's also written in anticipation of the expected change in strategic direction following the publication of Lord Darcy's investigation for NHSE, and it's framed around the well-known live well domains that we're trying to frame our strategy around. It's an ambitious programme, and you might expect me to say this as Director of Finance will require continued focus on us living within our funding and indeed delivery and supporting the move towards out-of-hospital services, also necessary for sustainable systems. So happy to take any questions, although of course many of the authors of this document are also in this room, and we've also got Narendra as well to perhaps support some of the questions here. So papers coming for board support, Chair.
Thank you very much, Howard. And you, just for clarity, aligns with Darcy and what we know of so far on the 10-year plan, aligns with the ICS strategy and the joint forward plan as currently laid. Okay, lovely. Then let's note that, Tom, if we could. Nick.
Thank you, and we've received the intentions. I suppose, and I am the eternal optimist. However, I think you made the point there, Howard. I think what I heard you say was, yes, this is all great and exciting. However, we need to live within our means. And I think what concerns me is that with the very clear direction that ICBs seem to be pushed from what we heard from the Secretary of State into that strategic commissioning, I think the reality is that although we hear that there is growth in funding for the NHS, everything I've heard since is talking about effectively flat funding into the next financial year. So whilst I welcome the optimism and the direction in the paper, I think it would be wrong of any of us in the room to assume that we will be commissioning any new or exciting services. And I think the reality as we go forward will more be about difficult decisions we have to make about those services that we may continue, we may be required to deliver differently at a higher efficiency, therefore lower cost, but still with a high focus on good clinical outcomes. So I just wanted to kind of, our organisational reading of this was, it read very optimistic, and that's right, and we should be aspirational, and we should be driving forward, but the kind of more pragmatic execs that read this said, this is all well and good, but we've got a really difficult, compared with other systems, clearly our financial situation is better than. However, we do have some significant challenges, all of us, both this year and specifically into next year, around that flat cash, which I think, I'm certainly hearing that, I'm sure you are through your networks as well. So just wanted to make that point without dampening it. It's great, but pragmatically, it's going to be really tough to achieve this. And we may be in a position as a board of making some difficult choices into the next financial year about where we prioritise our work.
Yeah, I think we'd all be surprised if there weren't some difficult decisions to come. But do you want to reflect on that, Howard?
I mean, Nick's more eloquently said, I suppose, what I more bluntly said at the beginning. But yeah, the delivery of this really does require a continued focus on us living within our means. But likewise, in order to deliver that's just longer term sustainability, we also have to deliver stuff within this plan, don't we? So we have to get the balance right between the two things.
Yeah, no, good point. And I know that Nick is not saying let's not be ambitious. That's absolutely what he's not saying. But just realistically, there's going to be some difficult times to come. Yeah, Elaine, and then I'll go to Ed.
Yeah, I just wanted to pick up on the point about the strategic themes, because one of the comments that's been made in the government, West Streeting made, was this intention to shift from from hospital to community. And I guess in light of also what Nick's saying, I just wondered if you could expand a little bit on the intentions presented here with that in mind, if that's possible.
And sorry, just before you come in, Howard, Susanna, you might want to give a little bit of an update, future shift wise. Yeah. Okay, over to you, Howard. Oh, sorry. You go ahead. Yeah,
Mrs. Howard.
Oh, it's
another Howard.
I can update on the future shift work. So that need to kind of, revisit and think about our kind of overarching system strategy, integrated, involving all partners. We've been very aware of over the last year. We've taken an approach to that which has engaged a very wide variety of partners, and also looked at the issue through a variety of different lenses as well. Where we're at with that is that coming to the next ICB committee meeting, which is at the beginning of December, is quite a substantial document that sets out now and proposes a whole series of principles based on those conversations about how we can enable all of the different dimensions of a future shift, which include, of course, yes, hospitals, community, but many others as well. And also starts to build on the flesh of that by kind of demonstrating how we need to draw together, if you like, the different strands, different things, what we're doing, if you like, to align with that, so that the resources that we do have, we're pointing at the right issues. And also there's a very key theme of accessing the kind of untapped potential in our system that runs all the way through the future shift work, through our workforce. That's been a very worthwhile conversation. I know, Elaine, you've been part of that, but also through developments around new technology, as well, and also the untapped potential around broader system partners. So the untapped potential in our voluntary community sector, social care providers, allied health professionals, advanced practice, all of these different things as well. So very detailed document coming to the ICP. It'll be available at the beginning of December, and I would hope also to maybe bring this to this board in January.
Yeah, okay, thank you for that. And Howard, did you want to add anything?
I guess I'll need to repeat, I suppose, that the work is framed around the live well domains, and the whole intention of those domains is really to describe the work that we need to do to strategically move work out of hospital, which I know is the core part of our strategy, really. And there's a lot of detail, obviously, in that report to do that. And as Nick has said, it's very ambitious, which is right.
Okay, thank you. And Ed?
Yeah, I really agree. And Nick keeps stealing my thunder today. All these good points keeps getting ahead of me. It's been that way for a decade. Headlines in the news today: the public sector needs to live within its means by 2026, isn't it? So that's a very clear. That speaks to Nick's point very clearly. I guess one of the conversations we're trying to develop now. So this isn't about investment. This is about interface, which plays to your point, Elaine. We're looking at this particularly with the PCN test sites. Is where is the inefficiency at the interface between primary care, community services, acute services, social care, the duplication that isn't about investment, it's just about sorting out and simplifying and making better the resources we have. So I'd really like to see, because the intentions are great, as Nick says, but actually This is going to be about nuts and bolts of what we can do with the resources we have rather than additionality. And everyone is saying through the test sites, not just in SNE, but elsewhere, there's a lot of tension and frustration about things not working between organisational boundaries and between sectors. And it's not an intentional thing, it's just the way services have evolved over time and different cultures have developed. So it'd be great to use these intentions to actually stimulate more of a left shift, future shift conversation about what we could do with the resources we've got and how we could streamline and unify more. And given we've got integrated trusts, I think we're in a really good place to do that, and neighbourhood teams. So
Yeah. So use the threat as an opportunity.
Yeah.
Yeah. Okay. And finally, Amanda.
Thank you very much, Chair. So building on what Ed has said in terms of the resources and living within our means, I think part of that resource challenge is an opportunity around how we utilise our current estate, because we haven't got any new money to create shiny new buildings. We need to optimise and revisit what we currently have and make good. So I just wanted to make that point around the estate optimisation. Thank you.
Thank you, Amanda. So with those caveats, which I know I don't need to repeat, but should we say with the realism of the situation, we are asked to support the commissioning intentions as set out in the paper. Supported? Agreed? Done. Well done, everybody. Thank you very much. Even better, you've clawed back some time, so you can have a short tea or coffee break. So should we have a 10-minute break, and then 10 minutes sharp, we'll restart. So 10-minute break, everybody. Thank you very much. McKinsey gave it to me. Yeah, they said, yeah, great, Chair, you need this gavel. Thanks very much. Right, everybody, I'm going to restart us. Are we ready to go? We're ready to go. Let's reconvene with item 11, emergency preparedness, resilience and response. Laura, over to you.
Thank you, Chair. So this is for the board to approve this report. This is our annual report to board around the resilience basically in the system to respond to emergencies. I'd just like to start by thanking Chris Chapman, who has pulled this together for the system, and also the EPRR teams in our providers as well for all of the work they've done. So we report on this annually. I'm going to take the report as being read. You can see within it the dates that we engage with our providers around their assessments, and overall, following our review with NHS England's regional team, we are substantially compliant against the core standards. And for awareness, the core standards are a framework that all NHS organisations are held to account against. Within the report, you will note the outcome of each individual review, which were undertaken by Chris and in some instances with myself as AEO or Accountable Emergency Officer for the system. And you will note that Suffolk GP Federation, this is the first year that they have undertaken the core standards with us. We have pre-briefed the Chief Executive of the ICB and also the Chair of Audit Committee, the action plans which we will be working with for our providers through to January, the reporting of where those action plans have gotten to in January will go to the Audit Committee, who have been delegated oversight around any future monitoring or risk arising from this. Thank you, Chair.
Laura, thank you very much. And just a quick question from me. 43 out of 47 compliance, so we're substantially there. Have we got a trajectory towards fully compliant?
We'll be working through our own work plan against the remaining that are partially compliant, and these will be managed through the EPRR forum. We would expect to be fully compliant within the next 12 months.
So at the next report date? Yeah. Okay, lovely. Thank you, Laura. Any questions for Laura based on the report? Elaine?
Yes, thanks very much for the report, Laura. And my question was really around the risk, which you sort of touched on, so it'd be helpful if you just expanded on it a little bit. Because for those that are either non-compliant or partially compliant, it would just be helpful to understand how any risk is being mitigated while the work is ongoing to achieve the appropriate compliance.
So just to clarify, each individual organisation within the system is responsible for managing their own action plans and risks. And as an ICB, we have oversight of that, and we report into NHS England around the risks that we hold, so we're the assurance function. So we will be working with the individual providers around their risks and their action plans. We've set this as a very close date to January. And following on from that, we will be presenting a report to the ICB Audit Committee to provide assurance that our providers within the system are making progress where they aren't either compliant or are partially compliant. Thank you.
Thank you, Laura. And I saw Janet nodding in agreement to that. Thank you, Janet. Okay, any other questions? Otherwise, we're asked to note, of course, and approve. Approved. Lovely. Thank you very much, everybody. Item 12, winter and H2 priorities assessment assurance around preparedness. Andrew.
Thank you, Chair. I'm presenting this on behalf of Richard Watson and Liz Maloney. The ask is just to note this report. It's already been through SOAC, who's reviewed and provided assurance that the system response to the winter and H2 priorities letter received from NHS England has been carried out. Again, I will take the paper as read, but there are several things I'll draw to your attention. First of all is vaccinations. The data on vaccinations is embargoed because it's not yet been validated, and therefore we can't release that in full, but I've reviewed it and there's no concerns. We're performing well and performing exceptionally well for RSV vaccinations. The system is working well to respond to the change in escalation levels, particularly working with mental health providers, community providers, and 111 to get their submissions, which means that we've got a fuller picture of system escalation levels across the system than we will have had previously. Probably one of the biggest things to happen this month, this week, or maybe, this end of this week, is the implementation of Release to Respond by East of England Ambulance Trust, which means that ambulances that are waiting at the hospital for longer than 45 minutes will immediately release the patient to the care of the hospital and will depart. We've had an excellent response from system partners on this, really putting their shoulder to the wheel in getting behind this, accepting there is some risk attached to it, but nevertheless accepting that the global system risk is probably lower. We've recommended some enhanced quality surveillance during the implementation of this over the winter, and we'll follow that up through the appropriate committees that we've got, and we'll respond if we need to, if there's any big concerns from that. There's a range of long-term condition prevention, identification and management projects ongoing. And then finally, there is significant monitoring assurance on the winter plan through the existing committees of the ICB and also within providers as well. So happy to take any questions on this, but the recommendation is that we note this, and our significant discussions already happened at SOAC, which I've brought to your attention. Thank you.
Andrew, thank you very much. Any questions from board members? Otherwise, assurance received and noted. Done. Lovely. Thank you very much. In which case, item 13, the performance report for November 24. And Howard, I think I'm coming to you for this one.
Thank you, Chair. So the team have recently tightened up the performance report to include key messages and discussions from the System Oversight and Assurance Group. That's summarised in page 139 of the pack. And performance against the key performance themes for UEC, elective cancer and mental health. And you can see some of the areas of improvement and areas requiring work on page 140 of the pack. And the report also shows the relative performance of our two acute provider partners. The report is for noting, and scrutiny for system performance continues to be via the System Oversight and Assurance Committee. Thank you.
Thank you very much. So lots of input from SOAC into this and oversight on behalf of the board. Any questions, Elaine?
It was just a quick question to pick up on the collective action, the GP collective action, and the fact that the ADHD medications have been withdrawn, or the support for that. I just wondered if it's possible to expand on the impact on the community and any mitigation actions that have been taken to support that.
Okay, thank you very much. Maddie, would you like to respond to that?
Yes, thank you. And this probably relates to one of the items that's on the board assurance framework. So there's been no change as yet that has been implemented. There are different scenarios in different parts of the ICB. We're working actively with the acute providers, so that's ESNEFT, NSFT, EPUT, and our local medical committees to ensure continuity of prescribing and care to patients. So I'd probably be in a position to update more fully in about a month's time, I think. Thank you.
Should we put that on the action log for the next meeting, Maddie?
Yes, thank you.
Okay, thank you. I'll leave that with you, Tom. Any other questions, Nick?
So it was more, well, perhaps a question and comment. We heard from the Secretary of State that the ICBs will no longer have a performance role in the new NHS, or the NHS that is changing. I think we're expecting clarification of Royal's responsibility operating framework in January, but I just wondered, Ed, whether or not you'd had any early indication, or from Howard, early indication. Personally, I think it would be a real shame to our communities if we didn't consider to at least monitor the performance and crucially learn from each other. So I just kind of wanted to highlight that as it is a significant move away from where we've been. Personally, I think it's the more remote the performance management, then the greater risk is that you kind of get a bit lost in the weeds. We know that perhaps some of the region or NHS England will perhaps only concentrate on those areas that are that are really, deep red in terms of performance. We tend to be green in areas, amber in others, and sadly red in a few. But my worry would be that we'd lose some of the energy, the support, the joint learning from each other if we don't, as a board, maintain at least the monitoring of performance, if indeed the formal performance management shifts to, I'm not quite sure where. I don't think we've seen that yet. So Ed, I'm just interested in your...
Thank you.
Sorry to throw you that one blind, but...
No, thank you for that. There's a certain degree of nuancing around the words here, isn't there? But let me go to you, Ed, to respond on that one.
Well, I mean, first, I really agree with the principle of what Nick's saying, because performance and transformation are two sides of the same coin, aren't they? You can't do one without the other. So we want to continue that way of working. I think let's wait for the guidance, but my understanding is that systems with a greater track record of delivery will be leading performance with, in partnership with NHS England. Systems that are struggling more may feel more led through NHS England. So I suspect there's a nuance here, but I can't be sure until I've seen the guidance. But I think the principle of what Nick's describing is that we will want to continue our emphasis upon performance within the system, because it's, performance, quality, finance are all linked together. You can't divorce them, can you? They're the foundations of a great system. So I think it would be risky to disentangle, separate the two.
Yep. Agreed. Frida?
Just to bring up this point, if it's more, performance is more distanced, then that makes it more the feeling of more regulatory, and that can be quite negative on a system. Yeah. So that would worry me about it, would be the negative impact on us as providers if it was so distant away from the nuanced approach that we perhaps have with the insight that we have of each other.
Yeah, I mean, the principle is, isn't it? Keep doing a great job, perform well on quality, safety, and the money, and you'll keep that responsibility within the house, and that is a virtuous circle. So let's keep going in that way. Maddie?
Thank you. I just wanted to give the board assurance that primary care commissioning and performance is considered by the primary care commissioning groups of each alliance, and indeed the Ipswich and East group is meeting this afternoon. So although not covered in the detail of this report, is to give assurance that those groups are looking at performance and the associated support and transformation that's related to it. Thank you.
Thank you, Maddie. And Ed, did you have another point to raise?
Yeah, it was just on diagnostics. I think it's not an area that we've discussed at the board, and we probably at the SOAC committee thought we should give it more attention. So percentage of patients waiting greater than 6 weeks for a diagnostic test is 26%, compared to a 5% target. So I think particularly with the CDC that's going to launch imminently, let's see, hopefully that will have a positive impact upon that percentage, as well as the Ipswich Centre that will come as well. So I think if we could give a bit more attention to diagnostics at a future board, I think that would be good governance.
Yeah, that's a good point. And let's log that into the action plan, Tom. Thank you. Any other points or comments we're asked to note? So with that discussion around performance management and CDCs, etc., noted. Done. Thank you very much. Item 14, finance report. Howard, I'm going to stick with you.
Thank you, Chair. So I'll take the report as read and highlight key areas and updates for the board as usual. Firstly, just my usual reminder to the board of the following. When I use the word system in this context, I'm referring to the formal ICS partners. That's the Integrated Care Board, the East of England Ambulance Service, East Suffolk, North Essex Foundation Trust, and West Suffolk Foundation Trust. SNE system has an approved balanced financial plan in line with our £2.4 billion of funding allocations. And amongst the system partners, West Suffolk have a board and NHSE approved £15.2 million deficit plan, which is offset by surpluses from other partners, predominantly the ICB. This deficit was to be halved by 2025-26 and a balanced plan projected to be produced by 2026-27. In summary, at the month 7, so that's the period to the end of October, the ICB, East and ESNEFT have projections that are currently on track to deliver their approved plans, noting pressures and risks which are in line with those reported to the September board, including the rising costs associated with continuing healthcare, the strategic developments at ESNEFT, including the electronic patient record implementation, the orthopaedic centre and the green surgical hub, and the funding of the pay award. The board should be aware that we are working very closely with NHS England to fully understand the pay award issue, and so stated pressures at this point cannot be taken as final, so there's a bit more work, I think, to be done on that. The position at West Suffolk Foundation Trust remains our most significant financial risk for this and next year. As of month 7, the trust had a year-to-date deficit of 18.7 million against its approved 15.2 million deficit plan for the full year, with 5 months remaining. At this rate of expenditure, just a simple straight line extrapolation, the trust is heading for an unmitigated deficit of about £32 million or 17 million off plan. The trust has put forward a recovery plan with mitigations which have been put in place, and this is projecting a likely £28 million deficit and a best case £25 million deficit, so between 13 to 10 million pounds off plan with those mitigations. And the financial reports at September and October indicate that the measures currently in place at the trust are having an impact, and that the trust is ahead of its trajectory to at least deliver its projected likely £28.5 million deficit. And we know that the trust are hoping to deliver a better position than that in this year, which is needed as in some ways the final piece of the jigsaw really to be able to deliver an overall balanced plan for the ICS in 2024-25. As a system, we've also been looking at a range of non-recurrent mitigations that we can deploy to support the financial position, and most of those decisions have now concluded. So in summary, Chair, the position has stabilised based on October data, but still remains very challenged. And whilst the risk to the ICS not managing to deliver a balanced position has reduced due to the actions taken, it does remain a real risk, and the board needs to be aware that the results of many of our actions have basically used non-recurrent means, and that therefore we're going to be going into next year with a reduced financial flexibility. Just a quick note on 2025-26 finances that's been discussed or touched on a few times in this meeting, but the board will be aware, of course, of the recent budget announcements in relation to NHS finances and the changes related to NI contributions, minimum wage, expected to have an impact on the wider system. At this point, I'm unable to update properly on the full impact of that, as we are still awaiting formal notification of allocations and guidance, but it's clear that the financial position of the wider NHS, including SNE, will be very challenging next year, and we would expect to see a continued focus on costs and improvements in our productivity, which, as Ed has highlighted earlier, SNE is actually quite well placed to deliver. I will keep updating the board regularly, Chair, and I'll stop there and take any questions.
Howard, thank you very much. Let me just go to Ewan. Ewan, would you like to give us a West Suffolk update as we are now on the 26th of November?
Yeah, thank you, Will. So look, I think probably just first to say the true underlying position of the trust has been clarified over the last few months. You will remember the PA consulting report demonstrated there was a gap between income and expenditure, at least as far back, or recurrent income and expenditure, at least far back as 2019-20, along with a growth in workforce. This is probably a simplification, but probably the largest driver of that gap is a failure to deliver recurrent efficiencies over a long period of time. And there's certainly evidence, if you go back before 1920, of that being the case. As we have clarity in position, we'd just like to apologise to the system for the impact that the finances of West Suffolk are having on other parts of the system. Importantly, we do recognise the situation we're in now, and we're absolutely committed to resolving that over the next period of time. As Howard said, we are ahead of our financial recovery plan at month 7, and increasingly confident that we'll deliver on the 28.5 and go further. A lot of effort is now being turned to addressing the level of detail around 25 and 26 plans that will give the board confidence that those are deliverable. I think finally, just wanted to recognise that whilst there's been a significant impact on those outside West Suffolk in the system, the very hard decisions that we've needed to take over the last few months to rectify the situation has had a very significant impact on the staff within the organisation. I just think it's important that's recognised as well.
Okay, thank you, Ewan. Let me go to Chris, and then I'll come to you, Dave. Yeah.
Thank you, Chair. I just want to reconfirm what Howard has confirmed, that it has been a challenging position in terms of the overall deficit, and we have been using the various other non-recurrent monies to balance the books. It's not a viable option going forward, and it will have repercussions for the future. I just want the board to be aware that while we are trying our best to manage the situation, there are issues that may come up at a later stage in terms of managing our overall funding position. And there could be implications in the overall context in terms of other funding that we may receive if we achieve a balanced position.
Yeah, there's more at stake than the immediately obvious number. Understood. Yeah, thank you. Dave?
Thank you, Chair. Thank you, Howard, and thank you, Ewan, for your comments. I was just a gentle reminder to the board, really, that I think in our last meeting, we agreed that we would have a communication to some of our stakeholders across the ICB about what the financial position of the ICB means to them. And I suppose I'm thinking general practice, our voluntary sector, etc., and how this actually affects them moving forward.
Yeah. Good point. Ed, I'll let you pick that up with your with your comments and question as well. So I'll point about the paper. Over to you.
I mean, firstly, thank you for the update and for the apology, Ewan. I think that's gratefully received. I think in terms of communications, we've got the Integrated Care Partnership meeting coming up, where I'll be talking about the financial position, and we've got a cross section of the whole system there. We think that's the most appropriate forum to start with. Two other things I wanted to say is obviously just to remind the board we're going to pursue a strategic piece of work in the new year, looking at sustainability in the acute sector more broadly. And I think that will be a very important piece of work. But in the immediate term, just looking for Nick and Ewan's support, which I'm sure I'll get, is that I think we need an early planning discussion for 25-26 to think about what are the what's the plan. What are the difficult things we need to think through for the coming year? Because as Nick has said and as Howard has supported, it's likely to be flat cash or worse next year. So let's get in there early and think through creatively together how we're going to manage that.
Should we take that as an agreed action outside the meeting? Yeah. Sorry, do you want to feedback, Ewan? Yeah.
It was a different point, really. I just wonder whether Howard, I mean, recognising that one of the main drivers of our position is the delivery of non-recurrent efficiencies. I just wanted your sort of sense on where we are as a system. There certainly seem to be. Chris highlighted the sort of measures that have been taken to balance the position, but for providers, there's a lot of non-recurrent efficiency in being delivered so far this year. Just wanted your perspective on that.
Go on, Hal.
Well, we're having to find at least 13 million at the moment, plus we've set aside an extra 5 million as contingency, and there's other risks, I guess, around some other allocations in primary care and dentistry in particular. But the majority of the solutions that we're deploying are non-recurrent against that, effectively, some of which are non-recurrent funds we've received from NHS, some are utilising some of our available flexibilities, etc. So we can only use those once, I guess.
So the point wasn't really around the actions the ICB were having to take to balance the deficit. It's actually the sort of core delivery. So I mean, if I look at EE's performance, it's sort of 88% non-recurrent. I mean, there's some. That's creating some additional problems for us for next year, I guess.
Yeah, absolutely. Yeah. For the ambulance, in terms of their finances, you mean? Yeah.
Just put your mic on, Ian.
if we look across the providers, the sort of the amount of non-recurrent efficiencies this year are high. As I say, that's at the root of the problems we're facing. So I guess it's important that we don't find ourselves recreating that problem more widely.
If I could just comment. Absolutely on the ambulance service, and that's why we decided to do a proactive diagnostic on their financial position. The full report of that has already been accepted by them, and actually we're looking at the phase 2 now, which is basically looking at how the actions they need to do as a trust to try and bridge that gap even further. So the full report of that is coming to the January board.
Yeah. Okay. Thank you very much for that, Clement.
Thank you, Chair. Howard, just wanted to pick up on the external review in relation to CHC and wanted to consider if there's an opportunity to collaborate with local authorities with regards to how we can support the increasing level of need within the system, but also look at opportunities on how we commission packages, maybe using the local authority frameworks in order to achieve that.
That's a really brilliant offer, and thank you. Yeah, so the conclusion of that diagnostic has basically pointed to some very clear pathway developments that we've got to make to avoid people going to CHC in the first place, and that will require system working.
Yeah, good point, Clement. Thank you for that, Arthur. Okay, any other comments, questions? Susanna?
I was just going to say that in terms of that really important conversation for the Integrated Care Partnership Committee, at the same meeting, our social care providers and voluntary community sector organisations also want to kind of bring a bit of a discussion about the impact of the recent budget on them. So none of these things are things that we might have immediate solutions to, but it's really important to, I think Clement makes the point really well, consider all of these issues in the round and what we can do in terms of working as a broader system, in terms of trying to mitigate and kind of promote resilience in the system as well. So I'd like to invite you, Howard, to come along to that ICP meeting so that you can be part of that wider conversation.
Yeah, and emphasises how important it is to work as a system, and the fact that we're in a moving feast as well. Pete, did I see your hand there?
Yeah, just briefly, and I think on that note, I mean, we're having in Essex, of course, similar conversations with MSE in particular, given their financial position. So in relation to any kind of how we manage our markets, how we commission externally, the more that we can kind of think about that in the round rather than moving costs between organisations, I think the better it will be.
Great offer. Yep, noted. Thank you very much. Any other questions, comments or points? Otherwise, we're asked to note, and indeed we do note, and we note the challenge current year and indeed going forward as discussed. Okay, all agreed. Thank you very much. Item 15, the BAF. Amanda.
Thank you very much, Chair. So here we have our BAF for November, and since the last presentation at our last board, we've actually now increased the number of strategic risks by 1, and that is risk number 33 pertaining to the GP collective action that Maddie has alluded to previously. This risk was escalated from the primary care risk register by all 3 alliances, hence why it's here today. And there is further conversation and debate on that risk and how it's going to be mitigated and managed at a forthcoming alliance meeting. Maddie may wish to enhance at the end of this presentation. Then moving on to Quality Committee, as I've previously reported, there is a lot of proactive work being undertaken through that committee in terms of its appropriate risks. And at their last workshop, they actually considered and discussed in great detail adult mental health. Moving to the Estates Committee, which in fact met last week, they discussed and debated 2 risks that they own. One was around RAC and one was around the sustainability agenda. With regards to RAC, we had quite a lengthy debate on what our risk appetite might be, and we've agreed to revisit that at a future meeting. Now, in terms of risk, the actual board entry is reflecting RAC at West Suffolk FT, but we actually highlighted last week that it's actually broader than the hospital and actually covers primary care as well as the wider estate around POD, pharmacy, optometry and dentistry. And we heard from one of the colleagues that Region are undertaking a desktop in terms of RAC and the impact it has on POD, which will be further reflected as we move forward. Moving to our People Committee, we had yet again a conversation, debate and more on the current system workforce risk. And one of the actions from that conversation was for the subgroup of the People Committee to really get into more of the detail to mitigate and drive forward. And just thinking ahead to, well, thinking back to where we began earlier on today around the EDI broader agenda, I think one action that I'm going to take is to make sure that all things EDI are more explicitly reflected in our current risk entry. So that's something that I will take back following today's meeting. And then moving into more of our local risk management, as we've previously heard, we have an active risk and resilience group. They have now met twice since an enhanced terms of reference has been agreed. And that group primarily focuses on the granular risks pertaining to each directorate. So that was about 3 weeks ago, and lots of activity and planned action going forward. And to actually enhance our risk management in the whole, we're actually embedding and rolling out risk management training across all directorates and teams commencing early December. I will leave it there, Chair, but invite my fellow director colleagues maybe to enhance any particular risk that they are owning at the moment. Thank you.
Thank you, Amanda. So any exec colleagues want to add? Andrew?
Just for colour, the process of going through the quality risks and quality committee deep dives has been really valuable so far, and we've got some really useful insight that we wouldn't have done if we hadn't taken that approach. We are doing cancer in December, and we're in the process of collecting information on our cancer risk as well, so we can provide a further update to the BAF entry following that. In our recent quality committee, we did discuss that for some of the quality risks, we are unhappy with the level of mitigation and the quality of mitigation we're able to provide towards some of those quality risks. We haven't yet worked out whether we need to accept that limited assurance because there's nothing else we can do, or whether there's more that we can do, but we've started that process of understanding how we can develop better mitigations towards our risks where that is possible. Is that a fair reflection of where we got to, Elaine? Yeah.
Yeah. Okay, did you want to come in there?
Well, I think if Andrew just asked me to, I'll just, no, that's okay. So yeah, because I think one of the things we'd recognise is that having limited assurance, we absolutely do not want to have. We want to move to a position of having adequate assurance. What is good in the discussions we're having is recognising the reality of some of the challenges we're facing. So I think what is definitely opening up is transparency, good discussion, openness. We will continue to drive to try and get towards the adequate, but in some areas that might just prove to be difficult. So I think it's definitely helped having those deep dives to focus. So yes, I agree.
Yeah, thank you, Elaine, and thank you for making that point clear about facing the reality. That actually has been a bit of a theme for today, hasn't it? Ambitious, but recognising the reality. But that doesn't mean we shouldn't be ambitious. But yeah, okay, Maddie.
Thank you. Just as Amanda mentioned, the risk in relation to collective action, I think what's most important to you probably is to know the controls that we have in place and the assurances that we have in place. So we are working very proactively and positively with our LMC colleagues in Essex and in Suffolk, with regular touch bases and more formal meetings, and at each executive committee on a weekly basis we are giving an update on the current position. We are able to monitor the situation through various forms of data, as well as bringing the intelligence from those meetings. So I think we have the infrastructure in place to mitigate and manage in a positive way and the best that we can at present. Thank you.
Thanks for that update, Maddie. Okay, Ed?
It was just on the collective action to thank Frida. I know that some of your contributions with the Essex LMC have been incredibly patient-centred and helpful. And you know, behind the scenes, you've really made a difference, so thank you.
Lovely, thanks very much. Any other questions, points? Otherwise, we're asked to approve. All approved? Thank you very much. Item 16, ICP update, Susanna.
Okay. So I've brought along to the meeting, I think, 3 pictures to show the board by way of our update from the ICP. So this is the first one, and this is a picture taken 6 days ago. at a very important meeting chaired by Famwell as the chair of our People and Communities Committee. And this was an initial event to begin the process of co-designing how we can develop an insight and oversight model for the integrated care system. So this is about implementing the PhD research undertaken by Sue Conker at the University of Suffolk, and the 45-degree model for integrated community care. So this is about combining both bottom-up and top-down influence from people and communities in the ICS. And as you can see, the meeting was not only very well attended, but also there was really active participation, lots of energy around developing that. So watch this space. We've already got the 45-degree model operating in a number of different ways through the ICB, but also through the wider integrated care system. We're hoping through the Alliance as well to have a really strong model around insight and oversight. The second image that I'm going to show you is one that I've already referenced on today's board, which is that at our next Integrated Care Partnership Committee meeting, which is in December, the committee will be receiving basically a collated set of self-assessments against those 22 things that we distilled from those very detailed conversations around uncomfortable truths. So you can see there that all of our NHS providers have undertaken self-assessment. Thank you very much also to the ICB for undertaking a self-assessment as well. And in actual fact, there is a self-assessment going to be in the paper from Essex County Council as well. I'm sure it's just that the deadline for the meeting's next week, but I wanted to give you guys a sneak peek of what there is. What you'll see there is that, there's 22 things, which are really, as I said earlier on, they're the kind of bare minimum, really, of what we should be doing in terms of really thinking about the action that we all need to take around tackling injustice in across our health and care system. We're making progress across those, I think, across the ICS. There are a number of little cells that are picked out in blue there, and in the full paper that will go to the ICP, what they'll be about is where we've identified positive practice, so including some examples of positive practice in the ICB itself. So, for example, in the board engaging in that cultural safety training, which I think was a really important step, and we've built on further today as well. And then lastly, the last image I'm going to show you is this, which is that another major paper at our next ICP committee will be that full vision document for future shift. So as I said, it's around about 70 pages in length, and it does, again, distill from all of those conversations through a number of different perspectives, some really important principles that I think we can agree on about how we need to work in terms of going forward to move towards that left shift way of working, but also in terms of unlocking some of the untapped potential in our system as well. So that will be a major paper for the ICP as well. So the next meeting of the Integrated Care Partnership is on Friday, the 13th of December. Our chair knows that very well because it's your turn to chair on behalf of our 3 ICP co-chairs. The meeting is live streamed online and the papers will be available on the ICS website a week in advance. Thank you.
Thank you, Susanna. And just thinking ahead as well, that's a really important meeting on the Friday, the 13th of December, isn't it? I think the feedback on the self-assessment, future shift and so on, for the January board, the January ICB board will be really important. So perhaps, Tom, when we're doing the planning, we could allow a little bit of extra time, please, for that feedback. So any questions for Susanna? Elaine?
Okay, so thank you, Susanna, and thank you particularly actually for running the people-focused, the workforce session that I was able to attend in August. I thought there were some really good discussions came out of that to think about how there needs to be evolution as we look ahead to the coming years to make the future shift. My question is around how we start to translate that. I know you've talked about the document for the vision will be ready for the strategy that will be presented, how that then gets shifted into plans and the sort of timescale and mechanism for doing that, that would be helpful.
Thank you, Elaine. It's a really good question. So when I talk about principles, it's not just a set of principles about blue sky thinking about where we should be in the future. They're also really powerful principles about how we know we need to work if we're going to make progress, and also what are some of the really important things that we need to focus on as well. So in that are a number of very powerful kind of concepts. So for example, the progression framework, which some of you might see me discussing in the future shift work, it's set out in detail in the document. We've used it to summarise principles in every single section. And already I've been talking with colleagues around the production of the next joint forward plan, that could be a really useful lens through which we could then take the future shift principles, apply them to the areas of work for the joint forward plan, and really use that to kind of, make sure that we've got a joint forward plan that's not only aligned, but also is sort of supercharged, if you like, from those conversations as well. The last thing I just want to say about the future shift work is this, which is that one of the most, we were actually in this very room, we had a workshop in September to bring together the different strands. And one of the points that was made very powerful there was about the importance of culture. It's come up at the meeting today. There's a very, very detailed section of the document about culture, and I suspect that one of the things we'll want to talk about next year, and I think that the ICP hopefully will bring some energy to this, is having that system conversation about culture and the culture that's necessary for us to move to that left shift way of working.
Great stuff. Thank you. Thanks, Susanna Fanwell.
Thanks, Susanna. I just wanted to sort of comment on something you talked about. So at the People and Communities event that I think my takeaway on that was both, feeling very positive, but also I think a little bit of a challenge in the sense that, we've created an expectation. We have committed as a system to working with our communities and involving them in the way that, we deliver services. They've heeded our call. They've come forward. I think the energy, as you have said, and the passion, that was in the room. People really want to work with us as a system and be involved. So the challenge that we have is to ensure that we don't fail people and that we don't, deliver as expected. I mean, we are quite excited as part of that group to sort of take that forward, but I think it's everyone's responsibility and we all need to come together. So, watch this space. I think, we are onto something, and, we'll be providing feedback as part of that People and Communities committed to this group.
Thank you for that feedback, Fanwell. Lovely. Okay, any questions for Susanna? Otherwise noted. Thank you very much and look forward to the January report. Thank you. Item 17, Dental Commissioning Governance Review. Peter.
Yep, thanks, Chairman. This is a relatively straightforward proposal for the board. When we first received a delegation from NHS England, we run the governance through our alliances, and then we created another group that took decisions on behalf of the alliances. We found that's not as streamlined as it could be. So talking that through with Tom, we brought to the board a recommendation that the board directly delegates this to the Dental Committee, and then we report into the Oversight and Assurance Committee with regards to progress. The alliance connections will continue as they are now with all of the good work we need to do together, but we think this will be a slicker way of running the decision-making and deployment resource.
Thank you, Peter. Any comments or questions? I saw a number of nods around the table. We're asked to agree 2 recommendations to establish the Dental Committee as a subcommittee of the SOAC, and then to amend the scheme of delegation to delegate exercise responsibility for dentistry, primary, secondary and community to the Dental Committee. Everybody comfortable with both recommendations? Agreed? Lovely. Thank you very much. Thank you, Peter. Committee highlight reports. There are only 4 there. Amanda, am I coming to you for this one, or are you going straight for questions, or how do you want to do it?
I think we could go straight to questions, Chair, actually, from any member of the room, actually.
Yep. So they're therefore noting any specific questions. Oh, Andrew, thank you.
It's just a highlight from the Quality Committee. I think page 216 of the pack, 3 of the escalations have come up in discussions already, but the 4th one, just to make sure that you all have seen it, is The Quality Committee reviewed the quality impact assessments run by Suffolk Hospital in relation to their financial measures, and assurance was provided for all their financial measures that quality was being monitored sufficiently and they had processes in place to pick up concerns if they emerged.
Oh, good point, Andrew. Well made. Thank you. And we'll capture that in the minutes. Very important assurance for the board there. Thank you very much. Peter?
Just to note, Chair, there is a West Suffolk Alliance Committee update as well, but I'll link with Tom to get it posted after the meeting, but we can then bring that to the report.
Okay, thank you very much. Lovely. Thank you. Any other questions or points otherwise received and noted? Great. In which case, item 19, the attendance log, again, there for you to note. Any questions otherwise received and noted? Done. Thank you. Any other business non-notified to me in advance? So I'm just looking around the table. Wave at me as I look at you if you've got anything, but I don't see any hands raised. No other business. In which case, let's move on to questions from the public. Now, I referenced right at the beginning that we had 4, but just before we move to handling those, Simon, has anything come in during the meeting? No additional questions. So, in which case, how we're going to do this is, Simon, you're going to read out the 4 questions, one at a time that we've had, and then we've got an executive earmarked to give an answer to each one, I think is the way we'll do it. So shall I go to you first for the first question from Anthony Dooley, please?
Yeah, sure. So the first question from Anthony Dooley is as follows. Ed is reported as confirming the principles set out in the NHS constitution that care was free at the point of use. Could the board explain that if this is the case with regard to NHS treatments, why I was charged £26.80 for a recent NHS dental check? What money exists within the ICB budget to reimburse NHS dental patients for what is supposed to be a service free at the point of use? Or is this charging arrangement part of future developments within the wider NHS?
Thank you. And Peter, I'm coming to you for this one.
Yeah, thank you. So dental charges apply across the country and have been in place for many years. It's not unique to SNE, and the charges are not set by SNE. Some people do not have to pay the NHS dental charges, and on our website and on the national website we list those exclusions, which include those under 18 and those who are pregnant or have a baby in the last 12 months, and there's a list of other items. So if you normally pay for NHS dental treatment, the cost will be dependent on the nature of the need, and so there are 3 NHS charge bands. And so the band that relates to the one that Anthony Dooley paid was £26.80, which is a band 1 treatment. I hope that answers the question.
Thank you, Peter. Simon, back to you. Second question from Mr. Dooley.
Okay, so the second question is, re matters arising 6.5, Dr. Kelso's reference to physician associates. I understand there is a review with regards to PAs. Dr. Kelso reported that PAs were valued members of the primary care workforce. Assuming that this is extended to other PA roles in the NHS, does he and the board believe that view is shared by relatives of patients who have died by being misdiagnosed by unqualified PA staff? I thought you claimed the safety of patients was paramount.
Thank you, Simon. Andrew?
Yeah, thank you. Obviously our deepest sympathies are extended to all families who are bereaved in whatever circumstances. All patient deaths in the ICS are subject to a robust review process, and obviously we can't discuss matters relating to individual members of staff, but to confirm and for absolute clarity, safety of patients continues to be paramount.
Okay, thank you very much. And back to you, Simon, for Mr. Dooley's third question.
Which is item 8, workforce race equality standard. I was surprised at the apparent ignorance of the issues arising from the attempt by ESNEVT to outsource soft services at Colchester Hospital and other workplaces in Suffolk, manifest at the previous meeting in Bury, and disappointed that only one member of the board responded to my request to comment on the KONP bulletin that I distributed to all members, including Amanda. As some of you might recall, there was an item in the HSJ dated the 21st of June 2021 that reported that Epsom and St Helier University Hospitals NHS Trust brought their cleaning and catering contracts back in-house to boost workforce equality and support staff from minority ethnic communities. As a board, you cannot claim to promote workforce race equality and other equality strands whilst pretending to distance yourselves from what SNEF is seeking to do in violation of, in this instance, the workforce race equality standard, or do you?
Thank you, Simon. Amanda, over to you.
Thank you very much, Chair. Thank you, Anthony, for your question. So the outsourcing of soft FM services is a matter for the SNF board, and we know that that is an area of current consideration with no outcome reached per se at the moment. With regards to the wider workforce race equality standard and the disability equality standard that was referenced and presented earlier on today, we've had good discussion, good debate, and a lot of good actions arising from that presentation, which will be coming back to a future board meeting, in fact, in 3 months' time. Thank you.
Okay, thank you, Amanda. And then finally, Simon, back to you for a question from Albert Horn.
And that question is, would those doing the commissioning please explain how the decision not to proceed with the super surgery, the Cardinal Medical Practice in Ipswich, supports the ICB's joint forward plan, in particular the vision to deliver the best possible health outcomes for everyone of the 1 million people living in Suffolk and North East Essex, alongside messages from the government that this sort of community hub is precisely the model we should be moving towards. Can it be explained just what we will be getting instead?
Thank you. And Maddie, over to you.
Thank you for your question, Mr. Horn. And I think that Ed touched on this right at the very start of our meeting. We are sorry and disappointed that we have not been able to progress with the original plan, but we are very actively looking at a number of positive options, and we will be coming back to discuss those with patients, the public, and the board in due course. So it's very active work at present. Thank you.
Okay, thank you, Maddie. Thank you. Is that it, Simon? All done? Lovely. Okay, so thank you very much, everybody. It's... Oh, I'm so sorry. Thank you, Howard. I'm sorry, I wasn't watching closely enough. Please do ask your question. Do you need a microphone there? Have you got one?
Thank you. Barbara Robinson, I've been here before, you probably know me. I'd like to just ask a question on the back of that last question 4 about the cardinal practice. It isn't just cardinal practice that is under review, 30,000 patients for the north of Ipswich, where I live, but the County Council last week also pulled the requirement for the secondary school. We're in danger, and the board need to be aware that there's an appeal going on. I'm an interested party, and I will take anything you like to provide for me in terms of the health, blue light services, education needs that are enshrined in our local plan, which are being abandoned by the County Council and are under difficulty with yourself in providing the GP surgery. That's going ahead soon. They need to redo a health impact assessment for that appeal because the last one was wrong. It's not been corrected. I did bring that to you. So if you have your estates, have a look at these various appeals that are going on in the north. It has bearing on your pragmatic look to funding. It affects SEND services if the school is pulled, and it will have a huge impact on air quality because the whole of that site, 4,000 to 5,000 homes, was predicated on services on the patch. If they're not there, people are going to have to drive. We don't know if Northgate and Thurston, the schools in question that have been approached, will be able to cover this. So that's my first question. Be aware that there's huge changes going on which will impact and have bearing on you.
So just before you proceed, I'm temporarily stopping you with a suggestion of perhaps could we take that forward outside the meeting, I suspect we haven't got an answer for it now, but perhaps there's a discussion to be had outside the meeting and then formulate the board's position. Maddie, Clement, are you happy with us doing it that way? Back to you, Barbara.
Thank you. I'd like to thank you for persisting, the ICB, the commissioners, Ed, your deputy Richard, and Rinda, with us difficult living experience people. We are very grateful, and this is the end of a 20-year journey for me to see this happen. There is a correction needed in your paperwork today at 3.2.3. The reference to rehabilitation in that point in your paperwork needs looking at. The language is really important, and rehabilitation is quite a troublesome word at the minute in relation to the ME and CFS and long COVID service for the severely affected particularly. Rehabilitation may be appropriate to mild and moderate that the GPs will be seeing, but the severely affected, following the prevention of death report, which has driven a great deal of our discussion over the summer, the Exeter coroner, which has been taken on board and has been responded to in our specification pathway. We're grateful for that. That was a watershed moment. So we want to see safe care, we want to see accessible care, and we want to see links with research to establish causation and treatments in the future, which is fantastic, and we're really grateful for all the work that's gone into that. And finally, I came in July asking you to respond to a really complex case that had been taken into Woodlands. And the good news is that the ICB and everybody have pulled together, and that person is home now and wants to extend thanks for the support they've had. Thank you.
Well, thank you for both those latter points. The first one I think we'll say noted to, but thank you very much for that feedback as well. I know that board members are grateful to have it. It's not often we get positive feedback in that sense. So well, thank you for saying it, and we wish all involved well. So with that, I think we are 12:12. We're approximately, have I got my maths right there, 18 minutes ahead of schedule. Shall we say meeting closed? And the next meeting is the 28th of January in 2025, which I have to say is a year I didn't ever think at one stage that would ever come, I think, when at 2025. So we meet again, 28th of January, 2025, and thank you very much for this morning. Thanks very much, everybody.